Hello everyone, and welcome to the Liver MRI webinar series. My name is Seidel, and I'm the Customer Success Specialist at Collective Minds Radiology. Before we begin, I would like to thank everyone who have provided input on our feedback form. The feedback we gather help us provide more value to you as a participant for these webinars. So make sure that you take you some time and answer the feedback question that is sent out after each webinar. But if you missed the previous webinars, they are posted on our YouTube, which you can watch after this one. I'll send it to you in the chat. And I would also like to say that we would like to thank Bio Radiology Nordics, who are enabling this educational webinar series with their sponsorship. And with that being said, I would say that this webinar is a little bit different from the previous ones because we have asked you to bring your own case. So I'm very, very excited. I haven't personally looked at the cases myself, but I can't wait to see what you guys have been uploaded. So well done with the uploading. Our clinical board have carefully selected a couple of cases that are going to be viewed today by our dear friend, Dr. Maarten Thomeer, and of course the case owners, depending on their availability. I also have my colleague friend here, my colleague Frederick here today. And I will be your host today. And if you have any questions throughout the webinar, please use the chat function on Zoom or email us at support@cmrad.com. And with that being said, I would like with that being said, please, Dr. Thomeer, please take the floor.
Thank you. Can you hear me?
Yeah.
That's very well.
Maybe we have introduced Johan to him. Could you introduce Johan, Frederick?
Yeah, we can introduce Johan as soon as his camera is starting to work. So we will do that shortly. So I think you can begin, Maarten, and then we'll introduce Johan for his cases.
So let's start. So if I see well, there are 8 cases to discuss. So those 8 cases, I don't know the final diagnosis. I presume you know it. They are all pathologically proven. Let's go to the first case.
And Maarten, can you share the screen?
Oh, I will share the screen, of course. Can you see it?
Yeah, we can see it.
Okay, perfect.
Great.
So this case, as you see already a large lesion in the right liver lobe. But first look at the different sequences. So the first sequence is a T2 here. So it's bright on T2, hyper intense. The liver looks quite normal. There is some ascites in the abdominal cavity. Then you see a large black hole here in the center of the image. That's a dielectric effect that's typical for 3 Tesla imaging. So T2, it's hyper intense. And then on T1, this is T1 before contrast. This is the outer phase, and this is the in phase T1. So you see that they call it Christmas trees in the center of the cyst. Looks more for me like seaweed. And it's hyper intense on T1 and hypo intense on T2. So if it's hyper intense on T1, it can be blood, it can be melanin, it can be heavy metals or glycogen. So I presume, based on this, I would prefer to state it as blood residues. And also, if you see at the diffusion imaging here, this is diffusion imaging. There are also black lines, and I think this black line is susceptibility caused by blood. So I have more and more the impression this is a cyst with internal hemorrhages. And now the most important thing, if you have a cyst, is to look if there are enhancing parts in it. It's very difficult to evaluate, but I have the impression that there is no enhancing part in the cyst. So my diagnosis would be a bleeding cyst. an uncomplicated bleeding cyst. It's not the image of a cystadenoma. Then I would see septations, which enhance, and also it would be more lobulated. So I would present this as a cyst with red blood, and I would not do any resection for this. I would do a fenestration. There's no reason for resection apart from the compression on the organs. That would be my diagnosis. Johan?
Great.
Johan, you're there?
Let's see if we have Johan.
Because Johan has the answer. There's really no enhancing part in it. So I really think it's a simple cyst.
Let's see if we can get Johan on. I think it's gonna be okay.
Or maybe we can go to the second case, maybe.
I
Do
could.
you know the answer, Frederick?
Yes.
You're
Yes,
sure you have to know it.
I know the answer. Would you like me to tell it, or should we wait for Johan?
Yes, I'm very interested to know what the final diagnosis is.
So this is a hemorrhagic cyst.
Johan is there, I presume.
Yes, I'm here. Yeah.
Okay, very good. Johan,
Right.
please.
I just went looking for my webcam, but it will be without webcam. Sorry for that.
No problem. So I made here the diagnosis of a simple cyst who has bled, and there's no reason for resection, in my opinion. It can be fenestration would be enough. So that's my opinion on this case.
And then I would say, Maarten, you are absolutely right. So
Okay.
this is a pathologically and surgically confirmed hemorrhagic cyst.
Yes. And
So they did fenestrate the cyst.
okay. Fine. Let's go to the next case. Is that okay for you?
Absolutely.
Yes.
So the next case, there seems to be a diagnosis on it, but I'm not sure if it is the right diagnosis. But let's go to the case. So I presume it's a young. Do we have more information on this case? A new developed incidental lesion in an asymptomatic 74 male. So this should really help me. So what do we see here? This is I see the hepatobiliary face on the left side. But let's first start by the imaging before contrast and after contrast on MRI. So before contrast on the in-face imaging, you see there are some hyper-intense regions in the lesion. The lesion seems to be hypervascular, and there seems to be some parts not enhancing. So by the fact that the lesion has hyperintense signal before contrast, it means it has bled. There has been some bleeding in the lesion. So an FNH is not possible. There's no differential diagnosis which could give a clue to FNH. It looks like a scar. However, it's not an FNH. And also on CT, you see on the venous face a washout. On our FDG PET, it seems not to be enhancing. And then maybe the most important sequence is the hepatobiliary face, this one. I will enlarge it. So that seems to be quite large regions enhancing with Primovyst. Then the only differential diagnosis is inflammatory adenoma with possibly exon mutation, so beta-catenin inflammatory adenoma, or a beta-catenin adenoma without inflammatory component, or HCC. These are really the only possibilities. So, but by the fact that this is an old man, my diagnosis would be an HCC, without any doubt. So I would not make the diagnosis of an inflammatory adenoma in this case. Also important, I would not do a biopsy. I would do directly a resection. Because if you do a biopsy, you can have false positive, false negatives. You can biopsy in a part that there's only without beta-catenin mutation. So I would always recommend a resected lesion. Do you agree, Johan?
Completely, Maarten.
Do you agree?
Okay. Yes, completely.
Okay. So I don't think this is an inflammatory hepatocellular adenoma, but HCC. Okay.
And maybe we can also then recommend, if you didn't watch the previous sessions on adenoma, which was very extensive and in depth on that topic, I recommend you all watch that, which is also available in the Liver MRI
yes,
group
of course.
on Collective Minds, and the courtesy lecture of you, Maarten.
Yes. Let's go to the third case.
Maybe before going to this case, I'd also like to properly introduce Dr. Johan Deham from Yper in Belgium. And Dr. Deham, Johan, you have been a frequent Collective Minds user over the years. And I think once upon a time, you also said that I know a guy who is really good on liver imaging. And And it was Maarten Thomeer. So we thank you for that and for enabling us to also have this webinar series together with Dr. Thomeer. So with that introduction, Johan, maybe can you introduce the case?
Okay, it's case number
1.
Number 1.
No, is it? Yeah, it's case number 1. Sorry, yes.
Okay, I will go to the same case. So they can open it. They can open it up in my review mode. Yeah. Okay. Here it is. Actually, we have 2 different time points here. And you are looking now at the first time point, Maarten?
2016, yes.
Yes. In 2016, this patient on the liver MRI, we noticed a small lesion in segment 6.
This one?
This one, yeah.
So if I look at this lesion, it's a kind of targetoid lesion. And in the arterial phase and in the venous phase, it's only enhancing a little bit. Now, the liver, for the rest, doesn't seem to be cirrhotic or steatotic. So it seems to be a normal liver. And now I'm going to look at the lesion itself on the in-out phase. On the images from 2016, and this is in and out phase, yes. On the in phase, I don't see the lesion anymore. So if I don't see the lesion on T1 in phase, it can only be HCC, adenoma, or FNH. And now if I look at the out of phase, I see the donut sign again, the target sign. So this is a lesion with microscopic fat. So I would prefer the diagnosis for this lesion to be adenoma with subtype steatotic adenoma, but it can also be another subtype of adenoma, because you can only make the diagnosis of a steatotic adenoma if there is homogeneous and diffuse fat. And this is not the case in this situation. So my I would go for adenoma.
Mhm. This is what we also had in mind. That's also why she had a follow-up exam, 2017.
Okay, I will go to that images. So if I go back to the lesion down in segment 6, well, it's certainly not enlarged. It looks like the same entity. And if I go upwards, I see another large lesion here in segment 7.
Yeah,
it's a quite heterogeneous lesion, and I also remarked a lesion here in segment. They also call it segment 9. That's between segment 1 and segment 6.
Mm-hmm.
So
Okay, that's new for me.
2 lesions, and I have the impression that based on the in and out phase, they also contain a huge amount of fat. So this is the out of phase. You see also what's particularly interesting in this case. You see that patient has gain in obesity, and there is steatosis of the liver, and there is a new lesion here, which is full of fat, and the other lesion here in segment 9 is also full of fat. And this was the third lesion here. We notice, and this is not changed.
Yeah.
So what we see a new lesion, 2 new lesions maybe, or maybe they were already visible, but now they are enlarged, and they're full of fat. So, and on the in phase, they are not visible. So if they are not visible on the in phase, it can only be HCC, FNH, or adenoma. And it contains a huge amount of fat. So I would prefer the diagnosis of also a fatty adenoma, steatotic adenoma, or adenoma, or even HCC. Since it is a new lesion which appeared in 1 year time, I would go for resection, because there's it's highly suspicious for HCC.
Yeah, it is exactly what has been done. If you take the third series, 2020, you do see that the lesion has been taken out.
Okay.
And it turned out to be adenoma on the anatomopathology.
Okay. And which kind of adenoma?
I noticed adenoma. I didn't go into detail, Maarten. I did ask my colleague of the anatomopathology department, can you give me a few cases of proven adenoma, so that I could have some cases for you, but no, I have no further detail on that.
Case, I would still think more of a HCC than of a steatotic adenoma.
Yeah.
That would really be my what I prefer.
Yeah.
For diagnosis. Okay.
Yeah.
Then we go to the case 2. That's also from you, I presume.
Yes. That is a young lady which was followed for melanoma to rule out metastatic disease in the liver. Turns out she has a lot of cystic deformation of the liver, and then also an enhancing lesion, which is nicely in the center.
Okay, so I see a normal liver with multiple cysts. The cysts seem not to be complicated, but there is a hypervascular lesion in segment 5. This one, it's homogeneously enhancing. There seems to be quite iso-intense
late phase.
There seems to be no washout, so I presume there was no Primovis given, so we can notice if there's washout or not.
Exactly. I have. I don't have the luxury of hepatobiliary contrast
Okay.
at my well. If I want to use it, I have to
Pay it by yourself.
yeah, to ask my pharmacy up front. So
Okay. So, and on the in and out phase, there's no difference. And still here, again, the lesion is iso-intense, so it contains hepatocytes.
Yeah.
So my diagnosis would be either an FNH or adenoma. So if there are hyperintense regions on the in phase on this sequence, then it can only be an adenoma. But this is not the case. It's completely iso-intense. So this will not help me. Further, what can help me is if there's a scar in it. So let me look. Let me take a closer look in this lesion. It's very difficult for me to analyze this if there is a scar in it or not.
I didn't see a scar, no.
I don't,
Especially not on the T2s.
Maybe a small scar, or there can also be a small vascular structure.
Yeah.
So I'm not sure. I would give Primovist or Multihans to have a more reliable diagnosis in this case, but no signs of malignancy.
Yeah, indeed. Actually, we have followed up over a few years. It doesn't grow.
Yes.
But eventually, the large cystic lesion that you see, that was growing, and she was suffering from pain in the right hypochonder. And so they took off the roof of that cyst, fenestrated the cyst. You see the susceptibility artifacts there. And at the same time, they removed the lesion, and it was an adenoma, proven adenoma.
Okay. So for me, it's I don't know what you think.
It's hard for me also, but I have to do it. Yeah, I have to do it like that. Yeah. But the thing is, an FNH, even with extracellular contrast, it tends to be slightly hyperintense on the delayed phase. Your adenoma tends to be iso-intense or slightly hypointense. Then also, if you have a scar, of course, then if you have a T2 hyperintense scar, then you're almost certain. Yeah, but it's harder without Primovist.
What's typical for an inflammatory adenoma, on the other hand, is they are hyperintense in the venous phase, in the delayed phase. So that's a sign that is also proposed by Maxime Renaud in a Journal of Hepatology paper some years ago. So if the lesion is hypervascular and it's still hypervascular in the venous phase due to sinusoidal dilatation, it's an inflammatory adenoma. So
yeah, indeed, yeah.
And if it's iso, and there's a scar in it, then it's possibly more chance to be an FNH.
Yeah.
So sometimes it's quite difficult. So
yes,
really need
inflammatory ones are difficult. Yeah.
Primovist of Multihans to make the right diagnosis. And you could also go for a biopsy. Could also be a possibility instead of Primovist of Multihans, but we do not prefer to use biopsy because there's a chance. It's a small chance, but there's a chance of deadly bleeding from a biopsy puncture. Okay. Still some to go. Which one now? 3, I presume? Yes. I hope it becomes more and more clear for everybody. There's all the same rules you have to proceed to come to your final diagnosis.
Yeah, and I would like to remind everyone that if you have any questions, feel free to ask them in the chat, and I will read them out, and we'll see.
So here, what could you explain the case?
Actually, this case, it was sent to us as a mass in the gastrosplenic ligament.
Yeah, this one. Yes.
Yeah, indeed. Actually, we were in the differential diagnosis thinking of GIST for example.
Okay, I guess then it should be hyperintense on T2, I presume. No, and is it hyperintense? It's not hyperintense.
Not really. It's either it contains some hyperintense.
The nice again, I always say it, the in phase before contrast is so important. Here again,
Yeah.
it has the same intensity as the liver, so it contains hepatocytes.
Yeah.
So you're sure this is not an extrahepatic tumor like a GIST tumor or a splenic tumor. It has the same intensity as the liver. So this is really a liver tumor, which is exophytic.
Yeah.
Here again, there is no fat in the lesion on the outer face. It's hypervascular. There's no washout. And there seems to be some scar in it, but still, again, here, I'm not sure. It's surely not an HCC. It's too homogeneous for that, but it can be an FNH as well as an adenoma.
If I remember well, there's also a true FISP in it, which is a sharper, if you're looking for a scar.
Yes.
Yeah.
Do you think it helps because the true FISP or Fiesta, this sequence?
Yeah.
I always say to my residents, don't use this sequence because it's not a real T2. So
it's T2 over T1 indeed, yeah.
Yes, the TR is around 5 or 6, and TE is half of the TR. So it's not really a T2, and you really miss lesions. It's more, this sequence is often used in cardiac imaging because it's very, very fast. But if you use it as a T2, I would say don't rely on that.
Yeah,
But
actually
here,
the reason that
you see some inhomogeneities, maybe it's scar tissue, yes.
Yeah, the reason that it was used in the past, I don't use it anymore, it's 2016, is that we wanted to see a better delineation of the vessel in that time.
Okay.
But,
yes. For vessel imaging, it's perfect. So my diagnosis would be an FNH or adenoma. Do you agree?
It is proven FNH indeed, yeah.
Okay.
I think on the delayed phase that you can see some enhancement central in the lesion. Yeah.
Yes, I agree. But you can also have vessels around the scars.
Yeah.
And the problem is with adenoma, sometimes you have also enlarged vessels in the tumor. Okay.
If you take a look at the coronal T1, Maarten.
Yes.
Take a look at the coronal T1.
Yes.
There you can see the central scar, I guess.
Yes.
That's the best.
Yes.
The best image.
I totally agree. Yes.
Yeah.
So what did you do? Did you do a resection in this case?
This was resected, yeah.
Okay. Because of complaints or?
Because of the initial setup, patient had been told that there was a tumor and that it would be taken out. It turned out it was clear after the MRI that it was originating from the liver and that it might be an FNH, but still they prefer to take it out. And
okay.
Actually, our surgeons they are reluctant to surgery. I don't have so many cases that have been operated on. Yeah.
Mm-hmm. Okay, thank you. So we go to the next. 3 to go, I presume. Yes, this one. It's a male of 46 years. Is also a case from you?
Yeah.
So I put here different contrast phases. The T2 and then the in-out phase. Again, the in-out phase, I like that sequence very much.
Mm-hmm.
So this is the outer phase because they're black bordered, and this is the in phase. So this looks, in fact, looks quite the same as the previous one. You have an exophytic lesion in segment 4, which is iso-intense again on the in phase. So it can only be an FNH adenoma or HCC, contains, well, maybe a little bit fat, but I'm not sure. It's iso-intense on T2. And here again, there can be some scar tissue inside in it. So I will always do a primo-vista or a multi-hand scan in this case. But if I really have to choose, I would go for also here for an FNH.
That's correct.
Okay.
It's been taken out and proven to be an FNH indeed. Yeah.
Okay. But here for this case, there would be no reason for a section, of course.
It was
there's no steel or something.
Yeah, it was resected later on together with the gallbladder due to a problem of the gallbladder later on.
Okay.
So it was not taken out at that time.
Okay.
I really need to be lucky to have pathologic proof. My surgeons they don't like to operate.
Okay. Okay. That's why they are surgeons. So next case, this one.
Yeah. So it's actually this was an exam setup for MR angiogram.
Yes.
And so we had a coincidental finding in the liver.
Okay. And one of the most coincidental findings in the liver are hemangiomas. Apart from cysts, and this is so this looks like a normal liver, as you can see. And again, the in and the out phase here, I put it here. The lesion is hypointense to the surroundings, so it cannot be an FNH adenoma or HCC. It's extremely hyperintense, as hyperintense as the gallbladder lumen. So it's a liquid, it's a fluid lesion. But it's a fluid lesion which enhances peripherally and a little bit nodularly. And there's in the later phase, there is the centripetal enhancement. So this is a clear diagnosis of an hemangioma. Yeah. There is sometimes you have to differentiate with that's very seldom, but can happen. Sometimes you have angiosarcoma, primary angiosarcoma of the liver. They can also have a peripheral nodular enhancement and hyperintensity on T2, but they're more of a wild type. They're more heterogeneous, and also they contain old blood in the lesion often. So hyperintensity on T1. But this is a clear diagnosis, I presume, of an hemangioma, and normally there is no reason for resection of this lesion.
Yeah, that's also it's not a case of the liver. We have like I guess 100 of hemangiomas that you see each and every month, but again they don't take them out. So this was the only case that I have of a hemangioma that was taken out. Yeah.
Quite exceptionally is the hyperintensity of the lesion. It looks like a cyst, a cyst, but it's in fact it's a fluid lesion, but it's not a cyst.
Yeah.
Okay, and on the last case. Here again, I put different contrast phases near each other. But this looks a nice case.
Yeah, it is. Actually, this patient had an MRI, had a CT 2 months before. And at the CT, it was mentioned that he had a lesion with a central scar. Again, we were biased in a direction in this 74-year-old man.
Okay, so it's a man, so an adenoma is very unlikely. Then you see there are iso-intense regions in the lesion, but there are also more hypo-intense lesions on the in-phase imaging, as you can see. So there are different, it's a kind of, you can also call it, they call it in the Lirac classification, they call it as a mosaic or nodule in nodule. So you have different parts in the lesion, and that is always suspicious. You should always think about the HCC when you have different intensities. If you have mosaic perfusion also, and above this lesion has also a washout, as you can see here. So it's hypo-intense in the venous phase. So it loses its contrast, and it's lower than the surrounding liver. It can also be a pseudo washout, but that's only the case if there's a lot of fat in it in the lesion. So let's now look at the in and out phase. So on the left side you have the in phase, and on the right side you have the out of phase, and doesn't seems to get darker. So there is no fat in it. So this is not. In this case, this is not a pseudo washout. So this is a real washout, and you should be careful, because even if there's a scar in it, a washout lesion with mosaic perfusion is very suspicious of HCC.
Mm-hmm. Another thing, Maarten, for a benign lesion like an adenoma, maybe an adenoma, but an FNH, would you think that it would have a mass effect on the gallbladder, like you see in this case?
Well, yes, I presume yes. It could be, could have. It could have, yes. It's mass forming, so could have compression on the gallbladder. And there seems to be also a capsula here. There's a hyper-intense capsula surrounding the lesion, but that can also be a pseudocapsula. So,
Maarten, we got a question. So, what is a mosaic perfusion?
Mosaic perfusion. So there are different. There's kind of partification of the tumor. So there are parts which are enhancing more or less, or they have a different intensity on different sequences. So this lesion is not homogeneous. There's an iso-intense region, and there's a region, other mosaic part, which is more hypo-intense.
Okay.
So if you have nodule in nodule, so if you have a nodule and inside it there's another nodule in it, always be careful. It could be an HCC. And if you have mosaic perfusion, like in this case, always be aware it can be an HCC. So in this case, we would not do a biopsy, because if you do a biopsy, there can be needle seeding of the tumor. So we prefer to do a resection.
Yeah, is exactly what has been done now.
So this is a HCC in a non-cirrhotic liver, and we see it quite often the latter years. And it's often due to steatosis of the liver, NASH and FLD. But I have the impression also that often I don't see any fat in the liver. So there are quite normal livers with HCC. I see it more and more. I don't know what could be the reason for this.
One thing which was interesting for me in this case is if you take a look at the T2 and also on the coronal T2, that you really have this nice T2 hyperintense central scar. So
oh, this one, yes.
Yeah.
Mm-hmm. Yes.
So
but
be aware.
The other way, it doesn't enhance in the venous phase. So a normal scar you would expect enhancing.
Mm-hmm. But you have a clear washout. It's a Lirac 5, so that's no problem. But
you cannot say it's a Lirac if there's no hepatitis or there's no chronic liver. So the Lirac doesn't. It cannot be used for this case.
With hindsight, you might say that segment 1 is quite large, but that's the only thing that.
Yes, I agree.
Yeah.
Yes. This segment 1 is quite large.
Yeah.
So this can be used for liver disease, of course. Yes. Okay, that were the cases. So to resume, I think what I would like to learn to help you to understand the evaluation of liver lesions is always the same way you look at the lesions at the liver. So look at the T1, is it ISO or not? Look always on the in phase. Look at the T2 and washout. It's always the same, and so in most of the cases you can make a reliable diagnosis. So a biopsy is not needed anymore. Okay, are there any questions?
Yeah, let's see if there are any, final questions or anything. Let's give them a couple of seconds to see.
We just had one comment. Great discussion.
Yeah.
That's
yeah, it was really, yeah.
That's from the boss.
It was flawless.
Well, I don't think there's no questions coming in, but well done, Maarten and Johan. I mean, this discussion was really, really, really good. I think you did a really good job, but I think we gave it plenty of time for anyone to ask questions, and I don't think nothing is coming in. So,
well, it's also
it's
Asgard, so I think a lot of people are traveling abroad now.
Yeah,
so
yeah, definitely.
The reason.
Well, thank you everyone for joining tonight. I will send out a feedback survey and make sure that you fill it out. We would also like to thank again, Bayer Radiology Nordics once again, who enabled this educational webinar series with their sponsorship. I really, really hope that everyone's going to have a good rest of your day, and I hope to see you on the 27th of June for the next webinar. And thank you so much, Maarten and Johan, for viewing the cases today, and thank you for uploading cases as well. But have a good day, everyone.
Okay, bye.
See you.
Thank you so much.